polyps. So they are as a result of allergy or inflammation of the nasal mucous membrane. You can see the sinuses, the frontals, the ethmoid and the maxillary, as well as the sphenoids behind. So coming on to the definition of the polyp, a nasal polyp is a prolapsed, pedunculated or sessile part of edematous mucosa of the nose or the paranasal sinuses. Types, they are the types of nasal mucosal membrane polyps, bilateral ethmoidal polypi or the intraocular polypi. So coming on to the first one is the bilateral ethmoidal polypi. So etiology is very complex, may arise from inflammatory conditions such of the nasal mucous membrane, nasal mucosa called as rhinosinusitis, disorders of ciliary motility or abnormal composition of the nasal mucosa, cystic fibrosis. Various diseases associated with the formation of polypus are chronic rhinosinusitis, both allergic and non-allergic, called as NAIDS. Asthma, 7% of atopic and non-atopic asthma have polyps. Aspirin intolerance, 36% shows polyps. Central triad of nasal polypi, asthma and aspirin intolerance. We can expect 20% of cystic fibrosis patients to have polyps. Allergic fungal sinusitis, all cases have polypus or polypoid mucosa to varying extents. Cartagena syndrome, bronchiectasis, which consists of bronchiectasis, sinusitis, situs inversus, and then ciliary dyskinesia. Young syndrome, which consists of sinopulmonary disease and azoospermia. Church syndrome consists of asthma, fever, eosinophilia, vasculitis, and granuloma. Nasal mastocytosis, mucosa is infiltrated with mast cells with few eosinophils. Pathogenesis, collection of ECF in the nasal mucosa and middle meatus and the turbinates. So they become edematous, the polypoidal changes occurs, polypi which are sessile in the beginning becomes pedunculated and prolapsed. Later the pathology, macroscopic, arise from prolapsed mucosa of ethmoidal sinuses and hang down in the nasal cavity. So microscopic mucous membrane lined by ciliated columnar epithelium covers the polyp. If the polyp protrudes out through the nose, it may undergo metaplastic change to transitional and squamous stratified epithelium. Submucosal tissues in edematous and filled with ICF and loose fibrillar stroma crisscrossing. The white cells includes eosinophils are scattered in it. Site of origin, lateral wall of the nose, usually from the middle meatus. Common sites are uncinate process, bulla ethmoidalis, ostia of the sinuses, medial surface and the edge of the middle turbinate. They never arise from the septum or floor of the nose. Symptoms, any age, common in adults. Nasal obstructions may be presenting symptoms, loss of sense of smell, partial or total loss, headache due to sinusitis, sneezing and water nasal discharge associated with allergy, mass protruding from the nostrils. Signs, on anterior rhinoscopy appears as smooth, glistening grape-like masses, often pale in color, insensitive to probing and do not bleed on touch. They are multiple, often multiple and bilateral, long-standing cases present with broadening of the nose and increased intercanthal distances. Polyps may protrude from the nostril and appear pink and vascular, simulating polyps. Nasal cavity may show purulent nasal discharge associated with sinusitis. Probing of the solitary using a Jepson's probe of solitary ethmoidal polyps may be necessary to differentiate from hypertrophy of the turbinates or cystic middle turbinates. So you can see a polyp over here. The diagnosis, clinical examination, CT-PNS exclude bony erosion and then expansion are suggestive of neoplastic changes. Simple nasal polypi may be associated with malignancy, so you have to rule out in all individuals with the age of 40 plus. X-ray of PNS helps to see the diagnosis. CT scan of the PNS, planned surgery. So X-ray of the paranasal sinuses, you can see this called as a Waters view. So you can see all the structures of the sinuses, like the frontals, the maxillary, and the ethmoidal over here. So you can see the right-sided maxillary sinusitis, diagnostic nasal endoscopy being done over here, and then the CT scan. The patient is being introduced into the console of the CT scan machine. So here is a normal CT scan with all the pneumatized pneumatized sinuses, very well pneumatized sinuses. And then you can also see the polypoidal tissues in both the ethmoidal sinuses, bilateral ethmoidal polyposis. So you can also expect left-sided maxillary sinusitis blocked by the sinus tissues and the polypoid tissues. So here both the sinuses are being blocked because of the bilateral polypoid tissues. So coming on to the medical management. So earlier polypoidal tissues revert to normal with antihistamines, and then control of allergy. Short course of steroids cannot tolerate should be given. So who cannot tolerate antihistamine initially, and then asthma with polypoid nasal mucosa. These short course of steroids are contraindicated in hypertension, diabetes, tuberculosis, pregnancy, bleeding, peptic ulcers. Surgically, polypectomy, intranasal ethmoidectomy, extranasal ethmoidectomy, transantral ethmoidectomy, and FAS. So endoscopic endonasal polypectomy is the gold standard method of treating these polypoidal mucosal changes or the polyps which have already occurred. Coming on to the intracorneal polyps, etiology exactly causes not known. Nasal allergy, infection, children and young adults, sometimes single and unilateral. There's three parts: the antral part, the conal part, and the nasal part. You can see the nasal part, the lateral wall of the nose, the middle turbinates, and then the intracorneal polyp coming out from the mucosa. Unilateral nasal obstruction presenting symptoms is the most commonest. Obstruction may be bilateral if the polyp grows into the nasopharynx and obstruct the other corner. Voice may become thick and dull. Hypernasality. Nasal discharge mucosa may be seen on one or both the sides. Anti-rhinoscopy. Smooth greyish mass covered with nasal discharge. You can see them. Soft, moved up and then down. You can pass the probe all around the tissue of the polyp. So you can see a globular mass filling the corona and the nasopharynx. Investigations: X-ray of the PNS, X-ray of the lateral view. Opacity of the antrum, you can see the opacity of the antrum on X-ray PNS. CT scan of the paranasal sinuses shows widened maxillary ostia with the polyp coming out through the opening. This is the intracorneal polyp in the antrum and the right-sided nasal cavity. So right-sided maxillary sinusitis is seen. So coming on to the differential diagnosis: nasal lesions, hypertrophic turbinates, rhinosporidiosis, malignancies, angioma of the nasal septum, nasopharyngeal lesions, adenoids hardly makes a differential diagnosis: nasopharyngeal angiofibroma, nasopharyngeal malignancies, glioma, meningioma, and meningoencephalocele. Blob of mucus, blowing the nose, hypertrophic middle turbinate, pink appearance, and hard feel on probing. Angiofibroma, history of profuse epistaxis, firm in consistency, bleeds on probing. Other neoplasms like fleshy pink appearance, friable nature, tendency to bleed. Treatment: conservative, not useful much of a time. So surgical endoscopic avulsion is the treatment of choice. Easily removed by avulsion either by nasal or oral route. Should know the oral route is not before it's a nasal route is with the endoscopic approach. Recurrence is uncommon as the mucosa is peeled off from the sinuses, which is the origin of it. Endoscopic sinus surgery is the treatment of choice, where we visualize the sinuses very well and then remove the part of the polyps which are the site of origin, at the site of origin. Enteroconal polyps grows posteriorly and downwards into the corona because of gravity, movement of the air current, direction of the ciliary ostia situated posterior at the framework of the nasal cavity, and then Bernoulli phenomena. The differences between enteroconal polyp and um, ethmoidal polyp are age, more common in children, and then more common in adults in the ethmoidal polyps. Etiology. Infectious etiology is more common in the enteroconal polyps, and the allergic etiology is more common in the ethmoidal polyps. Numbers solitary in enteroconal polyps, ethmoidal bilateral. Origin maxillary sinus, and then ethmoidal polyps or ethmoidal sinuses. Backwards, growth backwards to the corona, anteriorly. Size and shape, trilobe, anterior, nasal, and conal. Small and grape-like masses. Recurrence uncommon. Ethmoidal polyps are common. Treatment polypectomy, ethmoidectomy, or FAS. Important point: if the polyp is red and fleshy, friable, and has granular surface in older patients, think of malignancy. All polyps rule out malignancy in the older one. So simple polyp in child, rule out glioma, encephaloceles, and then meningoencephalocele. Multiple nasal polyps be associated with cystic fibrosis. To evaluate cystic fibrosis, epistaxis are orbital symptoms with polyps